Welcome back to the Morning Brew for Thursday morning, March 28th. Yes, we are live here in Albuquerque on our brand new morning television talk show here called the Morning Brew. So grab another cup and stay with us. Our guest this morning is Dr. Richard Seligman. And Dr. Seligman is the medical director at the Presbyterian Sleep Disorders Center. Dr. Seligman, welcome to the Morning Brew.
Thank you. I'm very glad to be here.
Good to have you here.
So we're talking about sleep apnea today. Now, a lot of people have sleep issues. What do you think is the biggest reason people have these sleep issues? Because it seems to be like a rising issue. Is there any reason or that you can pinpoint on why people have sleep issues?
You need to look at sleep as you would look at physical activity, exercise, and nutrition. It's really right up there with how we're supposed to take care of ourselves. Mm-hmm. Before we start in on sleep apnea, better than a third of Americans identify sleepiness as interfering with their daily activities. Now, of that group, 7% will complain about being sleepy on a daily basis. This has profound impacts on quality of life, on the development of psychiatric disease, medical disorders, job absenteeism, ability to perform. There's a variety of different impacts that this is going to have. Getting back to the issues that both of you were asking about, what impact does this have? It's enormous.
Yeah.
We're going to get into some of the common disorders like insomnia, snoring, but we're going to talk a little bit about sleep apnea and give us the medical definition of what that is.
Apnea is a Greek word for pause. So you are looking at pauses in breathing during sleep.
Really?
These can be profound. I realized that when we were talking about this before, that you were somewhat staggered by the number of events that people will have at night, but it's not uncommon for us to see this more than 30 times an hour, and if that's happening, that's considered to be severe, particularly with oxygen drops. This has profound effects on vascular systems in different organs, leading to an incidence of stroke, heart disease, hypertension, renal problems, and so on.
We get a little video of a test subject, and he's asleep, and we're going to roll that, and you can see it here on the monitor. And describe what's going on with this patient here as the video starts. We're going to give you an example of sleep apnea right here. So now he's wired up with belts, and this is part of the testing, right?
This particular testing is somewhat limited. You can see it, the chest and abdominal belts. You can see some catheters, and he's doing a significant...
Now he's holding his breath right now.
He's not even breathing.
Significant
right
pause right now. This goes on for quite a few seconds.
I think in that one is with 45 or 50 seconds, almost a minute.
If we play the whole thing, I should point out before we go too much further that was a clip from Sleep Multimedia, which is a CD and online-based textbook that we use for teaching purposes. That was not one of our videos. I just wanted to put that disclaimer in before I got myself into trouble. But during a sleep study, after we've seen a patient, we have a questionnaire, we've spent time with the individual, we have a significant idea what we're looking for, then we're going to go ahead and do a sleep study, which is going to include the monitoring that you saw, including brainwave testing, and also looking at legs and chin tone, oxygen level, and a variety of other parameters. We're going to have 17 channels altogether, and with that information we can tell quite a bit about what someone's doing at night and then proceed with therapy if it's appropriate.
And when you talk about therapy, I know a lot of people, whenever they think about sleep apnea and fixing sleep apnea, they think of having to be wired up to a machine at night. Now, is that the only solution to sleep apnea, or are there other therapies?
At this point, positive airways pressure, and I'm leaving it generic for the time being, as opposed to saying CPAP, which is continuous positive airways pressure, because there are other types of airways pressure we can use, remains the gold standard. Okay. We're going to spend a lot of time emphasizing to people weight loss, positional therapy, looking at their medications, seeing if we can manipulate those in any particular way having people change behavior as much as possible, because sometimes people will do things at night that they shouldn't be doing, such as alcohol or nicotine. I don't want to upset you folks because this is the morning brew, but there are people who are drinking caffeine at night who really shouldn't be, and all of this is going to interfere with sleep. We're going to correct those things. Okay. We are going to use CPAP. There are people whose presentation is mild enough to just use oral airways or mouthpieces. These will advance the mandible or lower jaw. This will sometimes change the position of the tongue in the mouth and help without putting them out in all the wires that you ask about. There's some experimental nerve stimulation studies that are being conducted right now that may show some promise, but they're certainly not ready for forefront use.
Okay, but simple things such as working out, not drinking caffeine a few hours before sleep, and just keeping a good eating habits, something like that will help you get more sleep.
Just to amplify those things a little bit, the people who are sensitive, I will ask them not to consume caffeine within about 7 hours of bedtime. Oh. So for most people, that means they should stop in the early afternoon. We're asking for gastric emptying, getting back to your point, about 2 to 3 hours before bedtime, if at all possible. This is tough for people who sometimes work very late, but we're trying to emphasize this as much as possible, or at least make their largest meal the midday meal and make sure that that supper is lighter.
Okay. Let's talk about insomnia for a second, Dr. Seligman. This is something that you see in your office all the time, I'm sure. That there's some chronic insomnia. I mean, describe some of the various stages and levels of insomnia that you've seen with patients.
We all have transient insomnias. You know, these...
we all have a sleepless night now and then, right?
Well, you know, death in a family, change in a job,
anxiety,
all of that. You know, we all have those nights. Jet lag is an example of a transient insomnia. These are short term. If an insomnia lasts longer than a month, it's considered to be chronic. And we're going to ask things such as difficulties initiating sleep, maintaining sleep, or both, or just having restless nights. And sometimes there are other reasons for these other than just insomnia, which we characterize as a complaint as opposed to a diagnosis. So based on that interview, you may counsel people, you may get psychiatric help for them. We move on sometimes to cognitive behavioral therapy, which is a psychological tool that allows people to understand a bit more about the different reasons why they're having insomnia. Medication may be appropriate, but for the most part, we try and make it short-term or as short-term as possible.
Describe the facility you have over there. What do you have beds and people that your patients sleep in? You wire them up, and you know, give us an overview of what you have down there at the Presbyterian Sleep Disorder Center.
The main campus is at the Casement campus. The initial contact with the patient is in a classic office setting where an interview is undertaken, and then we have 8 sleep beds that are available there that are done every night of the week. And we're going to use appropriate monitoring for the questions that we're asking, because sometimes we're dealing with kids, or we're dealing with the elderly who may have complex medical problems, or we're looking for seizures. We have 4 beds at the West Side Sleep Disorder Center in Rio Rancho, and I'm also affiliated with the facility in Clovis, which has 2 beds. So these are all part of the Presbyterian system.
It's amazing to me how busy you are. I mean, your patient backlog is, there's a lot of people that suffer from different sleep disorders.
Well, the numbers are staggering. You know, this is something that's been recognized on an increasing basis, so at least over the last 2 decades.
And just something that affects everybody. A lot of people are always worried about how much sleep should I have per day. What would be your recommendation?
It's an interesting question. You know, the answer to that, if you do a population survey today, is probably a little bit over 7 hours. Sleep scientists think that that's probably about as low as it can go. And this has to do with our 24/7 society and all the demands that we have on our schedules. Now, without indicating how old I am, I was in high school in the 60s, about the time that Kennedy was assassinated, which is why I can remember this. And at that point in time, we probably slept on average about 8.5 hours. Before Edison invented the light bulb, and changed things in terms of our ability to stay up, humans probably slept a little over 9 hours, because it's basically sundown to sunrise, and that's changed.
I would love to sleep that long.
Well, Dr. Seligman, thank you for being here. We're going to invite you back. We've got a lot to talk about in this area.
I appreciate it very much.
And breatheasap.com is the website.